Hi again, everyone. TJ All. It's I-45 now in Galveston now with another edition of UTMB's Healthcare Unmasked. And we welcome you all to the show. Just as a note, this has been pre-recorded, but if you have questions, feel free to ask those in our comment section, as we always do on this show. We do have folks standing by to answer your questions and send you into areas where you can find out more information. And when we say there are going to be questions, we think there'll be a lot with this one because there's an exciting topic we're going to be talking about, which is genetics in healthcare. And joining us now is Dr. Joseph Ray. He is the director and of the Division of Medical Genetics and Metabolism at UTMB Health. He's also an associate professor of the Department of Pediatrics at UTMB Health. Dr. Ray, thanks for coming on with us. We appreciate it.
Thank you. I appreciate it.
Let me just go with the most basic question. When we talk about genetics and healthcare, what are we really talking about there?
Well, genetics in healthcare has gone through several evolutions over the past really like 10 to 12 years. It started off mainly as a diagnostic profession. So when I got into this, most of my clinical interaction with patients was helping other physicians come up with a diagnosis. We were puzzle solvers, essentially. We would take these very kind of complex symptoms that patients had and help the other physicians put it together and come up with a diagnosis by doing genetic testing on the patients. Once a diagnosis was established, if we had good knowledge of that diagnosis at the time for like prognostic information or whether or not other physicians should get involved, we would help initiate that process. And then over the last decade or so, a lot of treatments have come out. And so our profession has evolved to include a lot of those treatments and is continuing to change as the landscape progresses.
And when folks hear about genetics in healthcare and for treatments and to diagnose problems there too, about how much of a timeline are we really talking about of where this is kind of emerged? I don't want to make it is an everyday approach versus just an every once in a while type of thing to use in healthcare.
I would say that at first it started off as just kind of a one-time thing of me meeting the patient and establishing a relationship and helping them come up with a diagnosis. And now long-term care for patients is a very common place for our genetic conditions.
And in fact, at UTMB Health, y'all are really trying to emerge this more as a specialized program within UTMB Health. Talk about that.
So, it's always been a specialty at UTMB. I took over this division back in 2014, and really my approach to growing the division has one to expand UTMB's presence in the adult population. So in the past, clinical genetics was thought of more of a pediatric specialty because the majority of genetic conditions didn't make it on into adulthood. And there are not that many adult onset genetic conditions, or at least we didn't think that there were. But now we've learned that a lot of those patients are surviving into the adult years, and there are a lot more adult onset genetic conditions that we're learning about. And so my approach in 2014 was to really expand the clinical footprint within UTMB to include the adult population. And now our focus is really taking on all these new treatments and offering them, or trying to be the first to offer them in the immediate area to our patients.
For those of you just joining us, this is Healthcare Unmasked, presented by UTMB Health. I'm TJ Alls of I-45 now and Galveston now, and joining us is Dr. Joseph Ray, who heads up the Division of Medical Genetics and Metabolism at UTMB Health. When we come back, we're going to be getting into what you heard Dr. Ray talk about at the end, the treatments. What's available out there? What's new? What's been around for a while? And what may be in the future? We'll have all of that when we come back after this word from UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.
Welcome back to the show, folks. TJ Alds of I-45 now in Galveston now, along with Dr. Joseph Ray. And Dr. Ray, when we talk about genetics, folks, they'll hear about that and they'll think of all sorts of things and high science and everything else. In your world, particularly when we're talking about treatments now, what's out there treatment-wise that maybe people don't realize for some everyday treatments that are available, but also for the kind of chronic illnesses that folks have to deal with on a regular basis?
I would say when it comes to treatment, the treatments that have been around for a while are ones for our metabolic disorder, which is why the division is the Department of Medical Genetics and Metabolism. Metabolic disorders are conditions where a person has difficulty breaking down certain parts of proteins, fats, or sugar that lead to an accumulation of waste product inside their body and causes medical problems. The one that people will hear about the most or have a little bit of an idea about is called PKU, stands for phenylketonuria. And this is a test that every child that's born in the United States is tested for. And we've been testing it for many, many decades. And so there are thousands of patients out there with PKU. And the primary way that we treat it is as soon as we establish a diagnosis of the baby, we remove all the protein from their diet and we replace it with a formula that has all the different components of protein except for phenylalanine, which is the component that they can't break down. And then we put them on almost a modified vegan diet where mainly the majority of their food that they eat are foliage and fruits and other carbohydrates. And then the majority of their nutrients come from this formula. And for a long time, that was their diet for life. And we found that if we started it as a baby, then they could live a relatively normal life and have normal intelligence. Whereas a baby who is not started on treatment would develop severe intellectual disability and eventually cerebral palsy and have a shortened lifespan. So that's the reason why we put it on the newborn screen. And there are hundreds of metabolic conditions. And today in Texas, we test every child that's born for about 54 metabolic conditions right at birth and intervene in that way.
And for folks that they'll hear this about screening of newborns, this has been pretty much a common practice, though, has it not, for most of these of screening, so you can know how to treat and deal with down the line?
Yeah, I mean, every child that is born gets a little heel prick, and they check that child's blood, and some of that blood is put on a little card that's provided by the Department of State of Health, and they send it off to Austin, and then there they test it for the 54 different conditions. And if it comes back positive, then they notify the pediatrician that takes care of the child, usually within the first couple of weeks of life. So by the time they get their 2-week appointment, the pediatrician will have the first set of results. And no news is good news. So if the pediatrician doesn't mention anything, then it's usually negative. But if it is positive, they usually get in touch with the parents. And it is a state mandated program. So if we can't get a hold of the parents in any shape or form, we will even go as far as like send law enforcement to the house to let them know that their child came out positive for the test. So it's a pretty big thing in Texas.
And one of the, let's talk about what's out there that you deal with, that you see within genetics used in healthcare, particularly on the treatment side of things, to give folks kind of a deeper dive into that subject now. Sure.
Some of the more common genetic conditions that people are familiar with are ones that they see on TV. So achondroplasia, which is the most common short stature condition, that particular condition people are familiar with because they can actually see them walking around out there. And really the highlight of this condition is that when the child is born, they have a gene change that reduces how the limbs grow, specifically the upper part of the limbs. So you see this fancy word up here, rhizomelic shortening. That just means that the top part of the arm and the top part of the legs are short, which leads to their overall short stature. But with this bone abnormality, they develop a number of other kind of health-related problems that need active intervention and sometimes need surgery over time. And that's really been the traditional treatment for these patients, is if they move forward with this here. if they develop extra growth in, say, their neck, they can develop extra bone growth in that area. It can clamp down on their spinal cord. And if the child moves their neck in a particular way, it can shut off the blood supply in that area and be a life-threatening issue. And so those children would need surgery. And oftentimes we check for that before they even leave the hospital to make sure that neurosurgery doesn't have to fix that before the child goes home. They can also develop changes in their hips that lead to early osteoarthritis or bowing inside their legs that require active intervention. And then oftentimes these patients undergo what we call limb lengthening surgery. So if their limbs are not long enough to say, for a female to be able to reach down and take care of her own hygiene, they would do like a limb lengthening surgery to lengthen out their arms or legs to be able to do something like that. Now, most recently, we added a therapy that came out that allowed us to change this quite drastically for the patients. So traditionally, we tried things like growth hormone for these patients, and it didn't really make a difference because the problem is not with growth hormone, but the problem is with this really complex pathway that I put up here, this RAS pathway. And there's a new drug that has come out called vosoritide that actually works in an alternate pathway that essentially shuts down this problem with the person's gene, which is called FGFR3, and it allows them to grow quite significantly. Not grow like you and I, but we've seen them grow about a foot or so extra over what their normal adult height would be, which is pretty huge in the grand scheme of things. Some of these patients that were started on this drug are now able to, this little kiddo right here is able to actually reach the pedals to be able to ride his own bike, able to put his arms above his head so that he can actually swim. There's been a number of cases out there where the parents have talked about the child being able to do normal stature things. I put some quotes up here. The child's legs are getting longer, so they're not needing surgery. My child is actually able to prefer her own female hygiene now. Can now link their hands over their head and behind their back, and tie their shoes on their own. So a lot of positive things have come from this particular therapy.
And I think one of the things we want to kind of stress, you and I had a pre-interview and we were talking about this, is that this is not because, particularly in the little people's world, there has been so much of an effort for many, many, many years for folks to accept them as they are and not to think of it as a problem. What this is really, the force is the push on this is the health conditions that do come with this condition. And calling it a condition only for the treatment side of things is that, as you pointed out, simple things in life that can be interfered with, but by using the genetics can help in so many ways of dealing with the physical problems that may come from that. Someone is still going to be of a little person's stature, but thought about changing them to be big people. It's about helping them with their conditions along the way. But there are parents who want to make some type of treatment to help out along the way. Can you talk about, because that's part of what you have to sit down and be sensitive to, but at the same time, work with the patient, work with the parents sometimes to find what's the goal here to take care of.
Yeah, you bring up an excellent point. So this therapy is not openly accepted by every little person that's out there. There's certainly a psychosocial aspect that has to be contended with, and that is the fact that a lot of that community has spent time trying to recondition the thought process about being a little person and whether or not it's a medical problem or not, whether or not they are normal versus abnormal. And I would say that thought process definitely has to be talked about in the clinical setting, especially when you're dealing with a family who has a child that is small and they themselves are small as well. To be uniformly small is something that is oftentimes pretty important to the parents. What we try to kind of paint in a positive light for the family in that particular situation is that unfortunately, our society is built around normal stature people. And so a lot of times accommodations have to be made for a little persons, such as like pedal extensions for cars, changing countertops within the home so that they can reach, changing the height of the toilet so that they can reach, or adding stairs so that they can get up to the toilet. Little things like that are easy to do not easy, but something that we can do in the home setting. But when you're interacting in a public setting, none of those accommodations are taken into account. And so there is a disadvantage interacting in society that was built around normal stature. The majority of the patients that I've seen that actually undergo this treatment are usually short stature children that are of normal stature, have normal stature parents. And you said it right. It's not going to change them into a big person. Adding a foot to a person who, is going to be around 4 feet tall or is not a lot. And so getting them closer to that lower end of normal stature. So if I can get a person to, 4'7", 4'8", by the time they're an adult, they could interact with their normal stature environment without a lot of those accommodations. And if I can add in the fact that you're not going to have a complicated limb length surgery, you're not going to have, a surgery in your neck, a surgery in your back, you're going to be able to take care of your own personal hygiene and not need help with those things. Those are all kind of positive lights to this. It doesn't change the fact that they're short. They're still going to be short. They're just going to be taller than the other people that are short in that community.
And it's amazing what can be done there with genetics. What are some other areas that folks may not be aware of that genetic treatments and therapies are available out there to better their lives if they have a health condition?
Well, the most common genetic condition out there that people hear about outside of the ones that we can see is a condition called cystic fibrosis. And that particular condition is what we call the most common autosomal recessive genetic disease out there. And the reason why is because it is about 1 in 25 people carry the gene change that's associated with this condition. So we hear about it a lot, and it is actually on the newborn screen as well. So we test every child, at least in Texas, and I want to say it's on the newborn screen across the nation as well, right at birth and at 2 weeks to check for this particular condition. But this condition, if you don't know a lot about it, is essentially a disease of the mucus. And so I've got a little good picture here. So we know that every kind of lining inside the body and tube inside the body has some sort of mucus in there. And the areas that we see a lot of mucus are in the respiratory tract, in the pancreas, inside the gallbladder. And if that mucus content is not regulated, it can become very thick and cause an obstruction. And when that obstruction occurs, it can make it difficult for us to oxygenate, so get oxygen inside our blood. It can make it difficult for us to get some of those enzymes out of our pancreas into our intestines so that we can process things like fat and absorb things like proteins inside of our intestines. So it can lead to a number of growth issues, respiratory issues, and then most of these people have a shortened lifespan because that mucus that builds up causes damage to the lung and invokes an inflammatory response. And once that inflammatory response happens, the lung eventually gets replaced with scar tissue. And once it gets replaced with too much scar tissue, there's really nothing that we can do. And I think I accidentally stopped sharing. 1 second.
So no, what's available there to help? Because as your slide shows, it's all about the mucus. What treatment is available via thanks to these genetic studies to make that easier on folks?
So historically, the treatment is like this. So we use things like hypertonic saline, antibiotics, steroids, these chest compression vests to kind of knock off the mucus from the wall of their lungs, and ultimately lung transplants and liver transplants for these patients. And that's been the traditional treatment for this for a very, very, very long time. Recently, we were able to come up with a drug that is able to drastically change the landscape for this, or the prognosis for these patients. So kind of understanding the mechanism of the disease is going to be the best way to kind of explain how this drug works. So over here on the right, you see the words delta 508 CFTR. That's one of the most common gene changes that is associated with this condition. And what ends up happening is it causes this receptor that's on the edge of the cell to get clogged up. So when you're trying to regulate the content, specifically the chlorine content inside the mucus, the chlorine stays inside the cells and is not able to get into the mucus, and that leads to a mucus buildup that's very, very thick, as opposed to the normal CFTR receptor over on the left that allows passage for those chloride ions to come through. And that's really the mechanism of disease for this particular condition, and ultimately how you end up with a bunch of mucus inside your lungs and in your intestines. The drug that we've come up with recently is a 3-part drug. It's called Tricafta, and it does 2 things. One, it works at the receptor binding site to increase the opening of these receptors. And so for the receptors that they're able to recruit to the surface, they're able to increase the amount of time that they remain open. So there's good kind of passive movement of that chloride ion at the surface. And then the other 2 parts of the drug are recruiting more of those receptors that are floating around into the cell to the surface. And so they kind of push everything up to the surface and keep them open for longer so that you have more time to regulate that chlorine content inside the mucus. And the results of that, we've seen that these patients are drastically able to reduce the amount of interventions that they need, drastically reduce the amount of infections that they undergo because of all that mucus buildup inside their system. It's also starting to show in the studies that it prolongs their life expectancy.
How common is this treatment being used now and in battling what comes from cystic fibrosis?
Not as common as you think. It's just brand new. So, we've had some of these drugs available from a research standpoint for a long time, but these just came to the market, and I want to say in the last year or so. So the cystic fibrosis centers that are out there in the nation have obviously probably taken these up very, very quickly. But some of the institutions where they take care of children with cystic fibrosis in a non-multidisciplinary setting, they might be slow to uptake for these medications because they may not have all the providers that they need in order to treat these patients.
And how common is cystic fibrosis within the population overall?
Oh, you're gonna make me do some math in my head. So 1 in 25 for Caucasians. So it's gonna be different for Caucasians versus non-Caucasians. Let me see. So in Caucasians, it's going to be 1 in 2,500. And then for the other ethnic groups, it's going to be closer to like 1 in 15 to 30,000.
Right. About 200,000 new cases a year according to the CDC. And so we're really talking about changing a lot of people's lives by having
absolutely
available that's out there. And it's amazing how being able to take that genetic, find the right code, and then get in there and make a difference in folks' lives. The biggest part of it, particularly for folks with CF, is to be able to, prevent that scarring of the lung transplants, which happen down the line, and the shortening of life. We're not going to say, at this point, it's going to be about making life regular, but for folks to deal with this. But it's amazing. When you were telling me about this the other day, I know several folks in my life who deal with CF and the challenges they've had to do. So let me ask you this: for somebody who's been maybe dealing with CF for a long time, is the treatments that are available now effective, or is there something coming down the line to help folks who may have been suffering from CF for a good while?
I mean, I think that they would still benefit from this medication. So it's not going to fix the active scarring that they have in their lungs, but at least it'll be a plateauing agent at this point in time to help prevent progression of the disease. Now, of course, there are patients that their lungs are too far gone and they still would benefit from a lung transplantation. But even with a lung transplantation, we would expect that they would eventually destroy those lungs too from the mucus accumulation. And so this would be a drug that you would use synergistically with a lung transplantation for an older patient who is lucky enough to get one. It would help preserve those lungs for a long period of time.
What are some other treatments that are available out there through genetic therapies, genetic treatments and drugs?
Well, the ones that, here, I'll pull up a slide here. The ones that are a little bit more, are not more inventive, but have been inventive are some of the, what we call exon skipping medications. And this is kind of the start of gene therapy for our patients. This particular condition, Duchenne's muscular dystrophy, mainly affects boys. And it is a condition where the child is completely normal at first. And then as they move more, they start to tear down their muscles. And just like cystic fibrosis builds up scar tissue inside the lungs, this condition builds up scar tissue inside their muscles. And the overall kind of clinical outcome of building up scar tissue inside your muscles is weakness. And so these kiddos, they start developing weakness. We usually start noticing it about 6 or 7 years of age. They start walking on their tippy toes and tripping a lot. And then by the time they're like 9 or 10, they're complaining about difficulty going up and down stairs. And then usually by the time they're a teenager, they're wheelchair bound. And for these patients, the muscle weakness starts from the top. So muscle weakness in the hips and the shoulder girdle, and then it works its way down. And eventually it'll work its way to the diaphragm, and these patients suffer from respiratory compromise. And so the prognosis for these patients before we knew how to treat them was about 25 to 30 years of age. And these are kids, or these are people who have normal mentation. So they have normal brain development and actually can like mentally understand that their body is deteriorating. So it's kind of a depressing condition. About 20 or so years ago, we learned that the reason why they develop so much scar tissue is because this tearing of their muscle tissue invokes an inflammatory response that encourages the accumulation of scar tissue. And so without getting too much in the nitty-gritty of this very complex picture, this dystrophin protein in the center of the picture here, the person with this disease is unable to have a long enough dystrophin protein to connect to the rest of the muscle tissue. And so every time the muscle flexes, you get this shearing mechanism that breaks open the sarcolemma, which allows all the muscle contents to spill out into the blood. And this process causes an inflammatory response that ultimately encourages the accumulation of scar tissue inside the muscle tissue. Now, the gene that I put up here, kind of getting into the nitty-gritty of gene therapy, is kind of a picture representation of how big this gene is and where all the problems can happen in this particular condition. And some really smart company out there decided to make a drug that allowed a person to have a gene change in one of these numbers here to skip over a drug that allows the replication mechanisms inside our bodies to skip over that problem and continue processing the rest of the gene. This particular condition, Duchenne muscular dystrophy, has two versions. One is called Duchenne's, which is the severe version where they die in their 20s and 30s. And the other is called Becker's muscular dystrophy, which is a less severe version. And they usually make it they usually make it to normal life expectancy. The difference between the two is where the gene change is on this particular gene. And Becker's muscular dystrophy are able to make a shortened version of the dystrophin protein, whereas a person with Duchenne muscular dystrophy has either a non-existent or very, very short dystrophin protein that's not able to connect to the outside portion of the muscle tissue. And so this medication that we were able to come up to, and I say we, this company was able to come up with, was one that actually affects the DNA during the pre-mRNA stage. And basically what it does is, I put a little dot here on 53 where the medical problem is, or the gene change is. And basically what it does is it lays this small kind of masking substance over that particular area. Let me zip through this. And I describe it to my medical students and residents as, it's basically like parking a Winnebago in that area, so that When a Winnebago is parked in a parking spot, you're not going to get in a parking spot, and you're probably not going to get in the one that's next to it either. And so when the replication mechanisms come by to replicate this gene and build out the protein, it'll see this Winnebago parked there, and it'll basically jump over it and ignore it. And what you end up with is you end up with a shortened gene change where 51 is attached to 54, and you ultimately change this person's diagnosis, as long as they're on the medication, from Duchenne's muscular dystrophy to Becker's muscular dystrophy. And so the outcome for these patients is a prognosis that looks like Becker's muscular dystrophy. So they typically don't lose the ability to walk. They typically don't have a lot of don't have to be on a lot of medications or have accommodations for their muscle weakness, and they usually make it through their adult years.
And that's this is an exciting thing for me. We're talking about being able to change a condition in which that is almost, it's going to take someone's life at some point, their adult life. And by this, not curing them or anything like that, but changing it to the point that now they can live a full life.
Absolutely.
It's amazing that just what looks very little, that Winnebago, as you say, on there, just changes the entire game within this area.
Yeah. And we have a kiddo like this that is in our clinic right now that's on this medication. When I first met him at 6 years of age, he was falling all the time. He was complaining about his legs hurting all the time because he was getting that muscle breakdown. And mom was very sad because mom lost a family member, her brother. So it's inherited through the mom. Because it's an X-linked condition. And so she had a brother that had this condition and passed away. And she started to see what she saw in her brother at that age in her son. And it was kind of a very, very trying time for her. And we started him on this medication, and the change in mom and the change in the kid was pretty drastic. I mean, the kid stopped complaining about his legs hurting anymore. He stopped falling all the time. He started walking normal. And to this day, many years later, I would expect him right now to not be able to squat anymore, to have difficulty walking upstairs, and he's still running around playing with his friends like every other kid out there. So it's a really, really drastic change for him, and it's a drastic kind of contrast for mom, the experience that she had with her brother, to see that her son is still doing all the things that her brother was not able to do at this age.
It'd be fascinating. We get to meet that youngster one day, get out there. Anything, before we move on to the next kind of topic here, I just wonder if there's anything else you wanted to cover on what you're seeing genetics, treatments and therapies out there too, that folks should be aware of, that they may not know themselves right now.
Well, I think the biggest thing that is on everybody's mind right now is something called gene therapy. And gene therapy is a medication that we use one time. And here I'll bring up another slide. This one is a little bit complicated. I designed this presentation for a different topic, but this particular condition is what we call spinal muscular atrophy. And it just recently got put on the newborn screen. And it is a condition that we call the second most common autosomal recessive condition, because where cystic fibrosis, 1 in 25 people carry the gene change for it, this one is more like 1 in 50, 1 in 55. So it's a lot more rare than cystic fibrosis, but it's common enough that we put it on the newborn screen and want to check for it. And this particular condition, the issue is with how the nerves grow. So as the baby is kind of growing in utero, the nerves start growing from the brain down into the spinal cord and out from the spinal cord and make their way over to the muscles. But that growing process requires a lot of complex mechanisms. And in this particular condition, if you're missing the SMN protein, then that growing process gets stunted. And if it gets stunted enough that the nerve doesn't end up reaching the muscle tissue, then the muscle tissue has no way to be activated by the brain. And so the muscle tissue just dies. And so here's a good representation of it. Up on the top is what I call a normal motor neuron. And inside the normal motor neuron, you see these microtubules, the connection points that are crossing between the channel here that allow the nerve to grow. And if you look at the SMA motor neuron down here, they don't have those crossing channels. And so that growth pattern is not happening. And so over on the right, if you're looking at this right picture here, the cell body is starting from the spinal cord, and then the channel and the nerves connecting to the muscle is what you expect. And a person with spinal muscular atrophy looks like over on the far right. The cell body is inside the spinal cord, but the connection points are not plugged into the muscle. And so the muscle is not working like you're expecting it to. And so the clinical picture for that is a floppy kid. The child has little to no muscle movement right when they're coming out of the mother's womb. Oftentimes mom notes that she didn't feel a lot of movement of the child in utero, and that person's life expectancy can be drastically reduced if that same process has affected the way their lungs work, specifically the diaphragm. So we check these children for it because now we have a treatment available for it, and the treatment comes in the form of a gene therapy. So a gene therapy is a therapy where we use a virus, what we call an adeno-associated virus, that acts as a carrier mechanism for a piece of DNA that can replace your DNA. And the reason why we use viruses is because viruses, that's the way they work. So when a virus enters inside your body, it actually enters into the cell pretty readily, and it changes the DNA inside the cell and uses the DNA inside the cell to replicate more viruses. And that's how a virus, spreads inside the system. Well, this particular virus has just one piece of DNA called a plasmid. And so when it goes and does its process, let's see if I can get it to zip through. When it goes and does its process, it's only injecting this SM1 episome inside the cell. And it takes over the part of the genome inside the kiddo with spinal muscular atrophy and replaces that. And then it replicates that over and over and over again to produce more and more of that SMM1 protein. And so the ultimate effect of that is that cell is now able to produce enough of that SMM1 protein to encourage the nerves to continue to grow. Now, this particular treatment has to be done early on in life, because the earlier, the better, because the nerves only grow for a finite amount of time after the child comes out of the womb. So if we can make the diagnosis within the first 2 weeks of life, you still got some time for those nerves to grow. The ultimate outcome of these patients is that they are able to start moving again. They're able to start walking, meeting their motor milestones like we expect to, and live relatively normal lives.
This is just so fascinating. I just find, as our conversation went last week, and then me just sitting here listening to you again, it is amazing of what is out there now. You brought up about using a virus to on this one treatment here, but I would one of the things is that was probably going to resonate with many of our viewers, because we have heard obviously of mRNA dealing with COVID. And that is, while we're dealing with it now, but that is kind of the new, I say new only because we're seeing it rapid. I just wonder, as you look at that and mRNA being able to use that for other things down the line, not just for, to treat a virus that may be out there, but other things. But how do you think that those fast forwarded studies dealing with COVID and using the mRNA platform will help in your field as we push forward and move down the line? Do you see kind of an acceleration now versus maybe what we saw 3 years ago?
Yeah, I mean, whenever a new kind of technology comes about, there's a lot of acceleration of different therapies in that area. I think that the mRNA is getting a lot of hype right now because of the vaccines, and I see us using it more and more with vaccine development moving forward because of the safety behind it. But as far as like its utilization for some of these gene therapies out there, I think that the majority of the research is going to be in, at least for these rare conditions, in the form of using these different viruses that we know are able to, because the viruses, like, we don't have to teach the virus to attach to a cell and enter into it. all we have to do is change what the virus is carrying. And so that part is done for us naturally through biology. And so it makes more sense as a mechanism to be able to use for gene therapy specifically. But do I see mRNA taking off quite a bit? I mean, absolutely. I showed you that first one of those medications called the exon skipping drug. When that technology came out, all these drug companies came out and tried to look for other conditions where they can use a similar skipping mechanism and try to create drugs for that, which is great because they've even got creative and went backwards. Instead of an exon skipping, they use it as an exon including. So for a condition where a part of the gene was being taken out because of the gene change, they would mask that area and keep it in so that the gene would not be changed and would not be broken like it was in the condition. And so I think that you're going to see some creative uses of mRNA. I don't think it's going to be the end all be all as far as gene therapy is concerned.
But it's another component within gene therapy to go along with what is already being worked on. It is fascinating to me, though, to be able to say, here's a virus, and we're going to let viruses do what viruses do, but we're going to make sure this one change is made so it's doing some good. It's doing everything else it's supposed to do. Get into that cell, change it up, but we're going to tell it exactly what we want it to do when it gets there versus a virus just kind of doing its own thing along the way. And I do want to kind of, so I can clarify when you say Exxon, I want folks to understand this is not the oil company Exxon is what you're referring to.
Yeah,
here.
I guess I'm using the right term. So exon is the coding region of our human genome. So the exon is the area inside the genome that contains our genes that we know their functions. Right. And then the introns are the rest of the genome. And in the past, we used to think that the introns were just kind of space-saving mechanisms. And now what we're learning is that there are a lot of genetic material in that area that also code for functions as well. And so we're just now learning about that stuff.
And also too, when we say just now learn, when we talk about, mapping the human genome and breaking down DNA, we're not talking about something that's, while it's always been looked at, but really understanding it, that's more of a recent thing when you take a look all healthcare in a timeline, that where we are now, 20 years, 30 years, 50 years by the time is light years of where things were not too long ago, right?
Absolutely. And you bring up a interesting topic. So while we know exponentially more than we knew, even 10 years ago, the human genome has been mapped for a really, really long time. We know all the genetic material that we carry inside of our cells. But our understanding of everything really is mostly about the exon region that I'm talking about. And to give you kind of an idea of how smart we are here in 2022, the exon only accommodates a very small percentage of all that genetic material. I'm talking like 5% of all that genetic material. So the rest of it does something. We just don't know what it does.
Right.
And so there's a lot more to be learned. There's a lot more areas that we can learn to adjust. And my suspicion and our theories is that the intronic information contains genetic material that modifies the exon area. And what I mean by that is if you take something as simple as like a person with blue eyes, you can line up 10 people with blue eyes and not any of them are going to have the same color blue eyes. It's all going to be different hues and different shades. But we know the genes inside the exon that code for blue eyes, and it just codes for blue eyes. But why do they all have different shades and hues? And our suspicion is that the intronic area contains genes that modify the exonic area that change the overall outcome of it. And that's the reason why you look like you and I look like me. We have a lot of the same genetic structures, but there must be modifier genes out there that change what the coding genes do.
And I think it's important for folks to understand here. It gets into the whole thing. We hear this a lot when research, particularly on genetics, is how much we don't know is way more than what we do know.
Yes, absolutely.
Right. Yeah. When you brought it on the exon side, it's 5%. But that 5% makes a lot of difference when you figure it out, right?
Yeah, for sure.
This is why I'm fascinated with this topic of, and it goes into, and I'm going to get into this a little bit of the future and the hopes that could be there. But for folks to understand too is that, gene therapy, gene treatments, genetic treatments and the like, kind of in a nutshell, explain how we go from someone studying something and saying, hey, this can help us possibly, and that phase to when we finally see something come to the market. And I use market in this case of being used in healthcare on a regular basis.
So repeat the question one more time. What was the time scale?
So folks can get a kind of an idea of, when someone says, if we look at this with some type of genetic therapy, and study this to deal with this condition or deal with this health issue, about how the process goes from that thought to actually getting use. Before, have we seen kind of a fast forward of that now as more and more things happen, just as we talked about with mRNA before, maybe fast forward some of these things. But yeah, so people understand the process of going kind of from the get-go to actual treatment.
I would say that if it's a brand new technology that hasn't ever been used on the market, you're looking at like a decade from the thought development process to actually getting FDA approved and used on the market. If it's a technology that we have a good understanding of, it's been used in other drugs or other therapies, then I would say that it probably cuts it in about half, about 5 years or so, just depending on one, how much funding the company has. So the more funding, the faster it's going to be able to come out. There's also, unfortunately, some political involvement in some of those things. And so if you have, or political and social involvement. So a particular drug that has a lot of media hype, it has a lot of endorsements and sponsors from, very high powered individuals in our society, you're going to see those things come to fruition a lot faster. Right. And that's just a natural thing, a natural way that our society works. Is like, have a Hollywood star that has a kid with a genetic disease, and that is able to get a lot of press for that. You're going to generate a lot more revenue or a lot more funding for that particular therapy, and the therapy is going to come out much sooner. But I would say if it's a brand new technology, about a decade. If it's a technology that we already know, then probably about 5 years or so.
And as you look at what's the future hold for genetic treatments and out there? Get your crystal ball out for me, Dr. Ray.
Well, gene therapy is our holy grail right now. Like that's the one treatment where we're actually able to get to the root problem and fix the problem. It's kind of Pandora's box though, when you start being able to adjust the genes to your liking, there is going to be a market for adjusting it to your liking when it doesn't have anything to do with a medical problem. So there are some definite ethical conversations that we need to have in the medical field before those therapies come to market. But my suspicion is a lot of these genetic conditions that I'm seeing on a regular basis are going to have gene therapies available. The big question that we have to ask ourselves is, if you change a person's genetic structure, is it permanent? And the thought process is we think it's permanent, but we see people's genes change all the time. I mean, you and I, we're being exposed to radiation from the Earth's core, sunlight, we're eating carcinogens. And so those things are changing our genetics on a regular basis. We just have good repair mechanisms inside our system that fix that problem. Now, when the problem doesn't get fixed, that's how you end up with things like cancers and stuff like that. And so the big question is, if I give you this gene change and change your genetic structure, is there a guarantee that it's going to be that way for the rest of your life, or could it get changed in the future? And so one of the questions that gets asked in the genetics field is, how long does gene therapy last? Like, is it going to be 10 years, 20 years, 30 years? And then I'm going to have to revisit the therapy in the future. And then when do you give it? So I talked to you about spinal muscular atrophy. We're starting those patients as early as 2 weeks of life. But at 2 weeks of life, most of the nerves have grown already. And so that you only get so much nerve growth between 2 weeks of life and 1 year of life. And so if they're prior to 1 year of age, starting them on that gene therapy is going to have a lot less of an effect, because there's not a lot of nerve growth at that point in time. So the question becomes, should we start that therapy in utero? And I think that that is going to be a hot area in genetics, where we start changing genetics of children while they're still being grown in the womb. That will be like a partnership between myself and like a maternal fetal medicine specialist, because they do that kind of procedure all the time, tapping into the blood of the child by doing an amniocentesis and then accessing an umbilical artery or umbilical vein and pulling off some blood. But in this particular situation, we'd be pushing that infusion into the child and changing the genetic structure in utero. That would probably result in a much better outcome for people with spinal muscular atrophy, because the nerves are growing so fast in utero. But then that leads us to the Pandora's box of, if I can change your SMN gene, what other genes can I change that the parent might like me to change? And so that's where the ethical stuff
and that gets to the white elephant in the room here, the ethical hurdles that are there. And this was an interesting part of our pre-interview topic between you and I, because you've brought up, and there's kind of two phases of this. Plus, we'll deal with utero versus particularly with the topics there. And by the way, folks, we're not talking about politics here. It's about, because right now there are there's certain guidelines you have within the medical field. You're a doctor, you have everyone's familiar with the Hippocratic Oath, so you got to deal with that. But then it's the new, as something comes on, the fact is the world has shown over and over again in our history that technology advances a whole lot faster than how the guidelines for the use of that technology can go into place. I shared with you my personal story of learning of history. My aunt, who is a professor at UTMB Health in the School of Nursing, focuses on medical ethics. This is her bailiwick, and she was just actually chatting with me about this, because she's done a lot of studies World War II of how Nazi doctors and nurses handle themselves, and by the way, how Jewish doctors and nurses who were in concentration camps handle themselves, where there was experiments going on and treatments and the balancing of how to take care of someone in front of you when you're also being forced to do things that yourself shouldn't be doing, but it's life or death. But now we're into this and part of what I wanted to make sure we address in the show is to understand, folks, that this is not something that's like, here are the rules and that's what it's going to be. It's something that evolves over time as you have an open discussion, is it not, of how to deal with the ethical challenges that may come down the path on everything?
I think the best approach is to approach it with an open mind. Our perception of things has evolved with time, and our tolerance of things has evolved with time. And to give you a good example would be the use of our plastic surgeons out there. When the plastic surgeons kind of first came to the market in the late 70s and 80s, talking about things like breast augmentation, there was a lot of negative press about that. There's positive press in certain industries, and there's a lot of negative press in the conservative industries. And over the last few decades, it's pretty much a readily acceptable thing these days, especially when it comes to dealing with our breast cancer survivors and utilizing that technology to make these patients have normal looking breasts again. So the cosmetic surgery area has undergone a lot of scrutiny over many years, but as we become more tolerant in society and have more of an open mind, we're seeing the additional uses for these things in other areas. And then it's so commonplace in our media these days that it doesn't really kind of faze us anymore. We see people with cosmetic changes, and for our actors and other people, it's just kind of normal commonplace for us. We don't even bat an eye at it anymore. And I think that this is going to be one of the areas where it's going to start off with a lot of scrutiny. It's going to start off with a lot of snub noses and a lot of like intense conversations, and then over the next few decades we're going to develop a tolerance to it and probably develop more creative ways to use it to see some medical benefits from it all, but it is going to undergo the same kind of scrutiny that all these new technologies undergo. And so the big question you put up here is cosmetic versus necessary. That's going to come about. We're going to have a wealthy family that comes to the genetics doctor and say, hey, I want you to make my baby have green colored eyes. Can you do that? And we will probably have the technology to be able to do that one day. And the question you have to ask is, are we going to do it or are we not? Is that tinkering with too much? And I think that the real answer is that if UTMB doesn't do it, somebody else is going to do it.
Right.
And so, what would I rather have the patient do it in, a controlled environment that I know that I can keep the baby safe and I can keep the parents safe and do it in a manner that I know there's going to be a positive outcome, or do I want to put the trust in somebody else that's out there that I don't know, and have my patient go there and get it done. The necessary aspect, right now, there's just not that many geneticists. And so the question that I'll get asked by my chair is, am I going to give up somebody's spot that really, really needs to see me for this patient to get this done? And I think that the answer to that is that we probably are not going to have that issue for too long once these things come to the market, because with these kinds of procedures and treatments that are available to these patients, there's going to be a huge influx of medical students and residents that are interested in doing genetics that are not interested in doing it today. When I applied to residency for genetics, it was not a competitive environment. There were not hundreds and thousands of medical students applying to genetics residencies. That's increasing now because there are a lot of genetics doctors out there that are doing treatments, which people are interested in. I signed up to be a doctor to treat patients.
Right.
So there's a lot more interest now. And when you have this available, gene changes where I can affect somebody in utero and I can do cosmetics versus medically necessary things and have all these this repertoire of things that I can do for patients, it's going to increase the competitiveness of the program. It's going to increase the amount of genetics providers that come out there, which is going to drastically lower down the wait time. Right now, the average wait time across the nation for a new patient in genetics clinic is about 6 to 9 months. Our average wait time here at UTMB is about 3 months, which is got us a lot of patients from out of the city. But I think that those wait times are going to drastically lower as more physicians come into practice in genetics. And this kind of thing here is going to attract more people to it.
And one of the things you and I talked about too is that there is going to be, I call it vanity treatments, the cosmetic versus the necessary. But folks are willing to, a lot of times on the cosmetic side of things, pay more money. And it becomes that balance too of, if I'm getting funding here for this, but this necessary, what we'll call a necessary procedure, there's not any funding for that anywhere. And insurance isn't paying the full rate. So how do that? And so, okay, do we set this price point here in the cosmetic side so we can afford to do this
Absolutely.
part here? And that's going to be one of the questions that will evolve over time, will it not?
Well, everything in our society is run by money, right? I wish that I could go to clinic and not care about insurance and, not care about meeting a certain, price suggestion from my bosses.
Right.
But that's just the way society works. And, medicine is a service industry. And even though, even nonprofit organizations still have to make money to try to break even. And so you bring up an interesting thought, and I'll reference our plastic surgeons again. There are a lot of plastic surgeons that go into the field that want to do things like reconstructive surgery and be involved in trauma cases and help impact people's lives that had an unfortunate set of events, or our breast cancer patients who had to have their breasts removed. They want to do those things and affect those patients' lives. But you're right, the funding for it is pretty scant. And so a lot of them have designed a practice where they're able to take the revenue from some of these cosmetic surgeries and translate it into the impactful work that they want to do. And so they they have a divided practice where they do the cosmetics for a certain amount of time, and then they use some of that funding to shunt over to the more impactful things that they want to do, and they have this balance that they work with. And that might be the case for the genetics providers in the future too, is that we take that funding from the cosmetic side of genetics and shunt it towards the more impactful stuff that we want to do, and fund research with it, right? And research is what is making all of this stuff a possibility anyways.
When you talk about the research, I wonder how excited you are being at an institution, one that not only you provide healthcare through your job, you educate through your position as well, but that you're in a university system at UTMB Health that really prides itself on the research side of things. Mm-hmm. Of that. And I know that you don't deal as much on the research side, but you have an interest into it. I just wonder though, where you're at now as you look at the future, just UTMB Health, of taking what you work in now and expanding that to really become, if anything, a center for excellence or a niche area that, hey, anybody in the country, you want to go for genetic, we're going down to Galveston, League City, or Clear Lake.
That's a great question. So one of the things that I've been working with our leadership team is really getting ourselves involved in some of these gene therapy trials that allow us to do some of the clinical trials at our institution. And then once they do get approved, we're already set up to transition it into a more readily available treatment for our patients. And I think that the clinical drug trials are going to be kind of where it's at for us, to be able to be the first to offer those therapies. A lot of those therapies are going to be done in an infusion setting. And so we're actually in the process of working on setting up an area where that is our focus. Our focus is, this is an area that we do gene therapy. We have all the providers and the services available to do gene therapy. We're doing clinical trials in the area. So we already have patients that are undergoing some of these things. And when it becomes commercially available, you can get it done here. And we have availability for you. And so that is definitely an area that our leadership team is focusing on right now.
Well, hopefully your office gets a little more crowded over there now.
That is the hope. Yes. It's already crowded with patients, but crowded with more providers as well.
Plenty of patients. It's having folks on your side of the table to help.
Yes,
out.
Absolutely. Yeah.
Dr. Joseph Ray, by the way, and I should, and trust me, I'm not the only one. He heard me say this before. We do think that Dr. Ray is using some of his own genetic studies to make him look a whole lot younger than he really is out there. First time I thought one of his interns had sat in on the deal. So, but such knowledge, and to be working on this as long as you have, and bringing it, it's an exciting topic, Dr. Ray. I am fascinated. I say this about a lot of the shows we do. I hope we have you on, several times a year to really talk about this topic, because I do think, while a lot with genetics has been around, like you said, the mapping of the genome has been done for a long time. We just are now starting to really harness that and getting into areas, but there's so much more to be done to learn about. But, the excitement, I just got a feeling after I talked with you the other day and then this interview today, that we are on the cusp of some really, we're going to see some bust throughs here in the next few years on a lot of areas, whether it's cancer, Alzheimer's, whatever it may be down the line, that we're really going to see some changes in lives. But at the same time, we're going to see those cosmetic things too along the way. And we're going to deal with those ethicals. And that's that comprehensive look at things. And I appreciate your passion in coming on the show with us here today. I really do, Dr. Ray. Thank you for coming on with us. We appreciate it.
I appreciate it. Thanks for having me.
The next time we have her, we'll get that youngster you were talking about earlier that's been able to play with his buddies again. I think that'd be a lot of fun to have him on with us. And
he has a good story. I'll see him here at camp here in a few weeks. So he has a good story. For sure.
Yeah, that's great. Dr. Joseph Ray, he's the director of the Division of Medical Genetics and Metabolism at UTMB Health. He's also an associate professor in the Department of Pediatrics as well. So, Dr. Ray, thanks for being on with us. We appreciate it. And again, this has been a pre-recorded deal, but you can go and as always, and watch this over again. If you have any questions, even here, you get an answer, email them to us. We'll send them on to Dr. Ray and get answers for you, and we'll bring them on a little bit later with us in the year as well as we see some new stuff emerge. Dr. Ray, thanks for being on with us. Before we close up, this word from UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit UTMB